So the lecture now is on approach to bone tumors, and we'll try to share some facts about how to go about managing bone tumors. You could also use another term which is called musculoskeletal tumors. If you do that, you are taking into the group the soft tissue tumors also. So there is a very terminology on bone tumors as well as musculoskeletal tumors. We'll try to stick to bone tumors specifically in the next 1 hour. So as you can see in the slide in the periphery, there are various types of lesions involving various different bones at different sites. But let me tell you, bone tumors are not very common. They can have a very varied presentation as far as clinical is concerned, radiological is concerned, or histopathological is concerned. So by the end of the talk, you will understand that it needs an approach in which many specialists need to give their inputs to take care of this difficult problem. Imaging has improved over the last few decades, and it has helped immensely in the care of musculoskeletal tumors. And mind you, still metastasis to the bone is one of the commonest tumor. And if a patient comes with a lesion and the age of the patient is above 60, it is always metastasis unless proved otherwise. It adds on to the confusion if it's a vertebral lesion and it's an old age patient. It could be a second differential could be osteoporotic fracture. Benign tumors are not very uncommon. A giant cell tumor, an in-between type of a tumor, is also not very uncommon. Being the tumor involving the locomotor system, the consequences create a lot of disability to function. If it is the lower limb, you can understand it affects the mobility, and if it's the upper limb, it affects the functionality of the person to a great extent. So with this, we start and see about how to go about managing bone tumors. It has to be a team approach. It is not only the orthopedic surgeon. You need specialists from radiology, pathology, radiation oncology, medical oncology, and at times you might need people from the vascular surgery side, from thoracic surgery and plastic surgery. So it's going to be a combination of many people, as you will understand as we go ahead, that every aspect is important. So the approach, uh, you would have probably three pillars on the approach. First would be the clinical, in which you need to look at the history and examination. Second would be the labs, imaging and the biopsy. And then third would be the planning the strategy of the treatment, trying to stage the tumor and treating the patient. So please be informed that a tumor is not equal to biopsy. As you can see, it lies somewhere in the center of the whole pyramid, probably more distal than proximal. History, physical examination is a very important aspect in the approach to a tumor, and the whole sequence of management has to follow this. And if you don't do that, it goes topsy-turvy. Meaning, if your first step is biopsy and you've not done the history exam, the labs, and the imaging, you're going to get in a problematic situation. So presentation invariably is a mass. It's painful, or it could be a presentation as a pathological fracture. What is a pathological fracture? A fracture which happens due to a trivial fall, or maybe a fracture which is having to happen without any trauma at all. Or the third presentation could be an abnormal imaging which has come up in the workup of a patient due to some other reason. So a painful mass is the commonest presentation of bone tumors. The pain could be activity related initially, or at times it could be no pain at all, especially in benign tumors. Benign tumors have this classical presentation that they should be painless, unless microfractures have started happening in the benign tumors. As time passes, as the tumor grows, the pain becomes continuous later on. It can progressively increase, and there could be, at the end, even rest pain and night cries. The character of the pain is not throbbing, and it is to start with dull, and as the severity increases, the character will become more and more unbearable. So there is one dictum which says that only mass and no pain is equal to a soft tissue tumor or a soft tissue sarcoma. So bony tumors are invariably connected with pain, especially the malignant variety. Questions that must be asked: in the workup of a possible bone tumor, the most important question is the age. Certain tumors are relatively specific for a certain age group. Classical example would be a chondroblastoma, which occurs in a epiphysis of a skeletally immature person. So if you go back to your books, you will find such tables which will give you an idea on which age group normally each tumor would present. But like you can look at this in Ewing sarcoma, it's going to be a pediatric age group, and multiple myeloma, it is going to be an adult or an elderly age group. So it's a very, very important single parameter which helps you in diagnosis of a bone tumor. Duration of complaint: benign lesions generally have been present for an extended period. It could be months or even a year. Malignant tumors usually have been noticed only for weeks or months, and the character of the pain has increased very fast. Rate of growth: classical example is an osteochondroma, which could have been there for a long time. The size might have increased insignificantly over the last 3 years or 4 years, but at the age of 30, there was sudden increase in the size of that mass, maybe pointing towards a malignant transformation. So the rate of growth, how fast the tumor has grown, gives you an idea about the biological behavior of the tumor, meaning how aggressive it could turn out to be. Pain associated with the mass being very important. Benign tumors are usually asymptomatic, as I told you. However, as they grow large in their size, microfractures happen within them, and that causes pain. Osteochondromas are a different type of lesions which could cause pain due to bursitis happening over them, due to they compressing certain tissues like nerve, due to blocking of joint movements, or very rarely being intra-articular and causing pain, or at rarely if they fracture, obviously they would cause pain. And malignant lesions invariably are painful, which is one of the diagnostic criteria. Aspects of physical examination: everything which we normally do in a orthopedic case, uh, general physical examination or local examination, depending upon where the problem is. We're specifically interested in the skin features. Is it shiny, distended, loss of hair, prominent veins? Is it warm as compared to the opposite limb? What exactly is the location? Now, this is the second most important pillar of diagnosis. First was age, and second is the location. Location meaning in relation to the bone segment. Is it in the diaphysis? Is it in the metaphysis? Is it in the epiphysis? This can be very well picked up on clinical examination. Definitely, it can be reconfirmed on imaging. All the details of a swelling, as you do in an examination of a swelling, tells you a good amount about what is the character of the lesion. The range of movement of joint, tumors would invariably spare the joint movement. The size, a large tumor, you're suspicious about malignancy unless that large mass has been there for ages. Tenderness may reflect a more rapidly growing process. Eggshell crackling on palpation is classical with giant cell tumor. Although lymph nodes are not very important in sarcomas, but as a drill, always do it. Certain sarcomas like rhabdomyosarcoma and those enumerated here will have lymph node involvement at times. This is a very, very important sort of a thing because it is so easy to take a biopsy from a lymph node as compared to the bone involved. So once we've done the history and the physical examination, we move on to the imaging, which is the central part of approach to bone tumors. Location and age of patient are the most important parameters in classifying primary bone tumors. As I've told you in the first part, these are the first two pillars. And it is very, very simple to determine from plain radiographs. Meaning you can easily make out whether it is a skeletally immature or a skeletally mature person looking at a normal X-ray. So what do we mean by location? A slightly crowded figure, but this is a classic from radiological clinics and an article of 1981 which still stands. And you can see that the location could be linear or transverse. And depending upon whether it is central or eccentric, linear or transverse, the presentations could vary. So for example, in transverse plane, if it is central, probably an enchondroma, eccentric, a giant cell tumor, an osteosarcoma, or a chondromic site fibroma. Cortical would be non-ossifying fibroma or osteoid osteoma. Periosteal would be a periosteal osteosarcoma or a benign osteochondroma. So, so this is a figure which shows you the thing I was talking about, the, the peripheral presentation, the intracortical presentation, or the intramedullary presentation. Reaction of bone to tumors. This is one important thing. The main reactions are of destruction, which creates lysis, of reaction from the bone side, which creates sclerosis, and a remodeling from the bone side, which is seen as periosteal reaction. So rate of growth determines bone response. If it's a slow progression, there would be a sclerosis all around. And if it's a rapid progression, there would be more of lysis. Now, reaction of bone to tumor, margin between the tumor and the native bone is visible very, very clearly on plain radiograph. Meaning, either you will be able to make out the difference between the tumorous area and the normal area, or there will be difficulty, or it will be just not clear. So slowly progressive process is walled off by native bone producing distinct margins in the form of a sclerotic rim. And rapidly progressive process destroys bone and the margins would be absolutely indistinct. Gradually, it'll mix into the normal bone all around. So radiographic margins are classically described by classification given by Ludwig et al. Again, a pretty old classification, but a very useful one. It classifies into 1, 2, and 3. 1 being least aggressive and 3 being most aggressive. As you know now that aggressive lesions destroy bone and aggressiveness increases likelihood of malignancy. But not all aggressive processes are malignant and not all malignant diseases are aggressive. So let's look at the three types. The type 1, a well circumscribed lesion with a narrow zone of transition. It's like a map in which the boundaries of a country are very well marked. That's why it's called geographical. So you can see in these three pictures, the first one has a sclerotic rim, and as you move to the last one, there's a bit of a fuzziness. However, there's a clear distinction between normal and abnormal. So type A would be a sclerotic margin. This is one of the examples. You can see a distal tibia in which there is an intracortical lytic area which is marginated by sclerotic tissue. The differential diagnosis you can see, and you will observe in the next three slides, this differential diagnosis would be similar, but just they will change seats from top to bottom. So the next geographical type would be 1B, in which there is no sclerosis, but the margins are very well defined. See the differential diagnosis, almost similar, but names going up and down. You can see in the X-ray an example of the upper fibular tumor, which has a very well defined non-sclerotic margin. And the type 1C, that means the most aggressive geographical type of a lesion, the margins become even more ill-defined, and you're assuming that this would be a more aggressive tumor. That is how the sarcomas are coming up in the list now. The chondrosarcoma would be at the top. The next type of lesion would be a moth-eaten lesion. There would be multiple scattered holes that vary in size and seem to arise separately, meaning they're all distinctive, small, eaten up areas of different sizes. Multiple myeloma is a classical example of a moth-eaten lytic lesion. You can see the same in the X-ray of this humerus shaft. Next is the permeative type of a lesion. It's poorly demarcated, meaning now the lesion is becoming more and more fuzzy from normal. There are numerous elongated holes, oblique slots in the cortex, which run parallel to the long axis of the bone. You have the schematic as well as the X-ray. This is the distal femur of a probably a aggressive tumor, could be an osteosarcoma. So they are elongated lytic areas which run both in the cortices and in the medullary area. They're becoming more and more fuzzy. And the differential diagnosis, as you can see, is invariably all aggressive sarcomas. So patterns of destructions go from geographic to moth-eaten to permeative, and they move from a less aggressive to a more malignant tumor. The periosteal reaction. Now, periosteal reaction is seen when there is mineralization. So it would take 10 days to 3 weeks from where the insult has already happened. This is important to remember. Now, the configuration of the periosteal reaction tells you about the nature of the inciting process, the intensity, the aggressiveness, and also probably the duration. Let's see how. Thick, uninterrupted periosteal reaction tells you that it is a long-standing process, often non-aggressive. Can be seen in stress fractures, can be seen in chronic infections. However, if you look at bone tumors, osteoid osteoma is a classical example for thick, uninterrupted periosteal reaction. Now, as it becomes more spiculated or lamellated, it tells you that it is an aggressive process and it is likely to be a malignant tumor. So the types of periosteal reactions, a bit of a crowded slide. It is just to tell you that there could be a very type of a presentation. You need not know all of them. It could be a continuous or an interrupted or a complex variety, and each can further be broken down into a single or a multi-layered. It could be with destruction of the cortex, without destruction of the cortex. So grossly, if you look at continuous periosteal reactions, are more with a more benign lesion. As it becomes interrupted or as it breaks the cortex, it becomes more aggressive, and the complex ones are seen with the most aggressive malignant tumors. The examples you can see on the right side, various types of periosteal reactions, osteoid osteomas, giant cell tumors, and sarcomas. Codman triangle, one important type of periosteal reaction. As you can see in this picture, a schematic which shows you probably a tumor of the metaphyseal area of the distal femur. You can make out that there's a cortical breach, there's a break in the continuity of the cortex. So once there is a breach in the cortex, the tumor extends into the soft tissue, making it more and more aggressive. And doing so, it breaks the periosteal reaction and leaves a small tent at one end in a triangular shape, which is called the Codman triangle. So if you see a periosteal reaction towards one side of a tumor and then there is a break, that is what is classically known as a Codman triangle and is indicative of a aggressive sarcoma. So periosteal reactions starting from solid to lamellated to sunburst to Codman triangle tells you that it is from less aggressive to a more malignant type of a variety of a tumor. Tumor matrix is the internal tissue of tumor. As you've already seen the classification, most tumor matrix is soft tissue in nature, so it is lytic on X-ray. When there is cartilage, you are able to look at rings, arcs, and dots on X-ray, classically seen in enchondromas, chondroblastoma, and chondrosarcoma, and bone-forming tumors will give you an ossific matrix. This is what we mean by matrix. On top is what is seen in ossific type of bone tumors. On the bottom, you can see cartilaginous bone tumors, which give you rings and arcs and a stippled type of an appearance on X-ray. So we've just done the history, physical examination, and imaging till here, and the conventional radiography till here, and it is emphasizing on you that we are almost close to a diagnosis even before getting to the histopathology. So radiographs are essential. Aggressiveness of the process dictates the response of the bone, and most helpful information now are three: the age, the location, and the margins on plain radiograph. Few other imaging which are important in bone tumors are the CT scan. It tells you about the cortical penetration in more details. It gives you the osseous details in the local area. It tells you about matrix calcification seen in cartilaginous tumor. It tells you about the neurovascular bundle relationship. And it tells if you do, you actually do always do a chest CT scan in an aggressive tumor to look for a distant metastasis. MRI imaging, it tells you about the intramedullary extent better than the X-ray. The margins which are fuzzy in X-ray will be more clear on the MR, which tells you about the intramedullary extent. It tells you about the soft tissue component in more details. It will tell you which muscle compartments are involved. It will tell you the relation of the neurovascular to the bone tumor. So the MRI tells you about the local extent of the tumor. The CT scan tells you about the local extent, and the chest CT tells you about the distant metastasis. Arteriography might not be a common part of imaging, but is useful in certain areas. especially in very, very vascular tumor where you would like to embolize the tumor before surgically managing. Bone scans are very important in the staging because they would tell you about one, a skip lesion. For example, if there is a distal femur osteosarcoma, you want to know whether there is a skip lesion in the proximal femur. It tells you about other bones involvement, and it is a huge investigation as far as staging is concerned. So chest CT tells you about the pulmonary metastasis, which is the commonest in bone tumors, and the bone scan tells you the skeletal metastasis, which is also not very uncommon. So the CT chest and the bone scan help you in staging the tumor. So only now have we reached the biopsy, which should be regarded as a final diagnostic procedure and not as a shortcut to diagnosis in musculoskeletal tumors. Nowadays, open biopsy is invariably done very rarely. It's a core needle biopsy, which is the choice to get a histopathology of bone tumors. You try to just give a stab incision, which is longitudinal. You try to avoid neurovascular bundles. You enter only one compartment. For example, you don't go through the deltopectoral groove, you just go through the anterior deltoid. The principle is whenever you take a biopsy, contaminate as little compartments as possible, because when you surgically manage, you take them in as contaminated and the biopsy path scar has to be excised with the tumor. Never enter a joint, avoid standard surgical approaches. Uh, Material from periphery is better because if you target the central point of the tumor, you might just get a necrotic area. So it is important to do your history, examination, and imaging before you do the biopsy because it might give you another very accessible area from where the biopsy can be taken. In that particular region itself, the MR could tell you and guide you the best path to take the biopsy, meaning the path which will contaminate the least amount of compartments. Your lab investigations at times might bring you towards diagnosis, classically in a multiple myeloma. In a pathological fracture scenario, the primary tumor biopsy helps you. And unless the workup is complete, even the pathologist, I tell you, needs the clinical, the history, and the imaging to come to a diagnosis in bone tumors. Why I'm saying this, bone tumor histopathology is not very easy. It always requires correlation. So if you have not done your investigative workup and your clinical evaluation, you are missing out on those pillars, and then the pathological diagnosis is a bit of a challenge. So always biopsy at the end of the workup. So we've done the examination, the imaging, and the biopsy, and now is the time to stage the disease. Staging the disease meaning trying to understand what is the local and the systemic extent of this disease. Why is this important? Because this actually tells you about the prognosis, one, and getting to know the prognosis, you are able to decide upon the approach towards treatment in the particular patient. So in benign tumors, as you can see in these images, the lesion could be latent, meaning it is lying there for ages. It could be active, meaning it is lying there, but it is gradually growing, or it could be aggressive, classically in a giant cell tumor. So depending upon various features, we on imaging as well as clinical presentation, we give them one staging, and then we could decide upon these that maybe a latent lesion, if not an imminent pathological fracture, can be managed by protection and keeping under observation. However, an aggressive lesion needs a care, which is invariably a surgical care. Coming to malignant, you stage the tumor depending upon the grade of the tumor, the site, and whether it has metastasized or not. So type 1 is a low-grade tumor. What is a low-grade tumor? Ewing sarcoma is always a high-grade tumor. Osteosarcomas are always a high-grade tumor unless it is a classical low-grade osteosarcoma or a periosteal osteosarcoma. Chondrosarcomas range from grade 1 to grade 3. So if it is a grade 1, it becomes a low-grade tumor. So depending upon the tumor type and its nature, you classify the grading. And then comes a compartment. A bone is defined as a compartment. Each muscle is defined as a compartment. So if it is pierce the bone and come out, it is called extracompartmental, and if not, it is an intracompartmental. Metastasis, as I've already told you, is either to the lung or to other bones, which needs to be picked up by a CT chest or a bone scan. So a stage 2 becomes a high-grade tumor, and again it is divided into intra and extracompartmental. And any type of the above tumors, if they have a metastasis, they fall into a stage 3. So as we go from stage 1 to stage 3, the prognosis of survival of the patient falls, and that is how our treatment gets individualized and modified. The most common stage in which most of the sarcomas of bone fall is stage 2B, meaning they are high grade, they are extracompartmental, that means there's a breach in the cortex, and on investigative workup, there is still no metastasis. Another type of a classification by American Joint Committee, which takes into consideration the size of the tumor. So they're again redivided less than 8 centimeter and more than 8 centimeter. And they bring in another factor, which is a skip metastasis. And the third thing which they have brought in is a non-pulmonary metastasis. So if it is a skip metastasis, it straight away goes into stage 3. So the treatment, benign lesions, if latent, kept under observation. If aggressive, needs invariably a surgical treatment. Traditionally, it would be an intralesional curettage or a resection if an expandable bone with bone grafting. In a very, very aggressive lesion like a giant cell tumor, there could be a recurrence rate of up to 30 to 40%. When we come to malignant tumors, the treatment invariably is neoadjuvant chemotherapy combined with wide resection. So neoadjuvant chemotherapy means that you give chemotherapy after the biopsy, before the surgery. Once you've given the cycles of chemotherapy, you resect the tumor with a wide margin. Once you've done your surgery, again start the patient on chemotherapy and complete the cycles. So this is a classical treatment of a malignant bone tumor. Mind you, the tumor type has to be chemosensitive. Classical example would be a chondrosarcoma. The classical ones are not chemosensitive, so their treatment is mainly surgical. That means you will not be giving them neoadjuvant chemotherapy. They go in for a wide surgical resection. Once you've done wide surgical resection in any type of tumor, they need to be reconstructed to give function to the limb. And then metastatic tumor would have a totally different type of care depending upon the primary tumor from where it has come. Principles of surgery, we'll just touch upon them to give you some idea. Now, limb salvage, meaning maintaining the limb in bone tumors. And like now we are talking about aggressive bone tumors, the malignant bone tumors is the standard of care. Neoadjuvant chemotherapy of bone sarcoma have helped surgeons to resect successfully some tumors that in the past would have been deemed unresectable. Also, the reconstructive possibilities have improved over the years, and the soft tissue coverage possibilities have improved over the years because of the collaboration of engineers and plastic surgeons. Amputation invariably has to be resorted to when there is a neurovascular involvement. That means the tumor is engulfing or surrounding the whole of neurovascular tissue, or displaced pathological fracture. Mind you, it needs to be a displaced pathological fracture. Just a break in the cortex is not a indication for an amputation. And a complication secondary to a poorly performed biopsy. This being one of the commonest causes of amputation in our country, and the commonest cause is that biopsy scar becomes infected, or the wound dices, or the scar is so big, huge, or wrongly placed that limb salvage is not possible. Questions before limb salvage: would survival be affected by treatment choice? How do the short-term and long-term morbidity compare? How would the function of a salvage limb compare with that of a prosthesis? Are there any psychological consequences? So try to look at this figure and understand what are the surgical margins. So as I've told you, bone is considered to be as an anatomical compartment, and each muscle in a particular limb segment is also considered to be an anatomical compartment. So the surgical margins could be that you do a intralesional resection, like a debulking, or a marginal resection. Invariably, this is done only in benign or locally aggressive tumors. Wide resection is when you take a normal cuff of 3 to 5 centimeters of normal tissue along with the tumor tissue. And a radical resection is one in which you take off the whole compartment. For example, if in a femur the cordyceps is involved, you take out the whole cordyceps. So a radical resection is excising the whole anatomical compartment. The treatment today for benign tumors which need surgical care would be intralesional or marginal resection. In malignant tumors or sarcomas, the treatment is wide resection. Radical resection is rarely done because the consequences which it creates is are very, very difficult to reconstruct. So on the right side, you can see what is meant. Both these principles could also apply when you do amputation. It is not just when you're doing limb salvage. All these principles of resection margins also apply to when you're doing an amputation. So an amputation, if required in a giant cell tumor, would be different from what is required in osteosarcoma. So the surgical outcome, the most important technical aspect of surgical procedure is attainment of wide margins, regardless of whether this is achieved by amputation or local resection. Upper limb is slightly different. Resection of an upper extremity lesion with limb salvage, even with sacrifice of one or two major nerves, generally provides better function than amputation and subsequent prosthetic fitting. It has two parts to it. One is that whatever function left is great function to the hand. And the other part is still we are learning and progressing on making good upper limb prosthesis. So this is a classical example of an Ewing sarcoma. You might debate on the looking at the top X-ray that it is not actually looking very aggressive. Why it is so? Because it is a post-chemotherapy X-ray. The patient has already gone through 3 cycles of chemotherapy, which has shown its response in the form of good sclerosis. And in the images below, on the right, you see the surgical margins. You dissect the tumor in such a way that you just are not able to look at the tumor. All this is done by preoperative assessment on the MR images, telling you on what all tissues are spared and what all tissues are involved. And after resection, you have reconstructed the gap by a cement spacer so that the patient can quickly go back to starting his chemotherapy. Lower limb outcome, if you go around the knee, the treatments are individualized, and if you go around the foot and ankle, amputations are probably a better treatment, and as you go proximally, it becomes more and more difficult. So to summarize, The surgical treatment involves wide resection and reconstruction. So the margins have to be wide, which is mandatory. You need to reconstruct the bone gap, and then there needs to be a soft tissue reconstruction. These are three main parts of the surgical care. And principles of resection, you need to isolate the neurovascular bundle first. You need to have a wide resection with a cuff of normal tissue, it is 3 to 5 centimeters. You have to en bloc remove the biopsy with the tumor and not dissect in between. And if the joint is involved, the capsule goes with it. Let's move to simpler tumors, which are the benign tumors, which at times can be managed by observation and protection. This is an example of a cyst in a child, in an infant actually, and it was managed by protection. It was definitely a needle biopsy. It is said that at times the biopsy itself is an adequate stimulus for the healing process to start. So on right, which is a totally lytic expansile area, to the left, the child has grown and the sclerosis has improved. So a benign cyst in a child is managed by protection and observation. And if you have slightly more aggressive giant cell tumors, you need to do something which is called curettage. You do a wide decortication, you create a window, you do curettage mechanically by either mechanical curettes or high-speed burr, and you add certain adjuvants in the local area which help you in eradicating the tissue. The normal adjuvants which have been described are bone cement, polymethyl methacrylate, liquid nitrogen, phenol, and various types of lasers and electrocautery. This allows us to do our local extension of the margin of the tumor and make sure that we have sort of taken care of most of the aggressive tumor cells. Bone cement is one of the most popular ones which is used and in say giant cell tumors. It helps you fill the cavity, gives you the mechanical stability. The heat produced when the cement is settling helps you do some extended curettage. However, it has certain downsides that it might produce degenerative changes in the descent joint. It has a good point. It helps you in picking up recurrences around the lesion very quickly. As you can see here on the right side is an immediate post-op. On the left side, lytic areas are again appearing. So the bone cement is a very, very good differentiator. You can easily pick up a lytic area coming up. To prevent degenerative changes coming due to the heat, you can use a sandwich technique. As you can see on the right side, we put certain bone chips in between the articular area and the bone cement area and try to protect the bone cartilage of the joint and prevent arthritis. Cryotherapy, not very easily available, but has been used as a local adjuvant, similar principle as you would have for other adjuvants. It helps due to freezing the tumor cells and crystallizing them, and they then break up. And it helps you to extend the local uh, area of treatment. However, it is not very frequently used. Phenol again has a killer effect on the tissue, but the problem is it could also damage the normal tissue around. So it's being used less and less. En bloc resection, it is done in expandable bones like the proximal fibula, areas where there's a very high rate of recurrence. And in recurrent bone tumors, when there's pathological fracture, joints are involved. This is one example of tumor care in which there's a very, very aggressive giant cell tumor, as you can see in the X-ray. The tibia is almost eaten off, and you have resected it, reconstructed by a customized artificial joint, covered it with gastrocnemius flap using plastic surgery techniques. Another example in which upper end of radius giant cell tumor has been reconstructed by taking the patient's own fibula and plating it to recreate the bone. Radiation therapy is not very commonly used in bone tumors. Most of the bone tumors are not sensitive. Ewing's is one of them, but more and more it is not being used because the chemotherapy has become more and more effective. So chemotherapy, you need to know these two words. Adjuvant meaning refers to chemotherapy administered postoperatively to treat presumed micrometastasis. And neoadjuvant chemotherapy refers to chemotherapy administered before surgical resection of primary bone tumors. So nowadays, the standard of care is you give chemotherapy after you have established your diagnosis, give few cycles, see the response, do the surgery by wide resection and reconstruction, and then restart the chemotherapy after the surgery has been done. There is one thing which is looked at the tumor specimen, which is sent after resection, which tells you about the tumor kill, that amount of cells which have been killed by the chemotherapy given before surgery, and it could guide you on to continuing the same chemotherapy regime or altering it to a different if the tumor kill is not great. So to summarize, at the end, we need to again understand that musculoskeletal tumors are not very common. They can have a variety of presentation. Imaging has improved care to a big extent. Biopsy is not the first stop. We need to do the clinical evaluation, the imaging. Metastatic bone tumors are one of the commonest, especially at the age of 60 and above. That is the first differential diagnosis whenever you see a bone lesion. Benign tumors are pretty common. A giant cell tumor is one of the common aggressive benign tumor. And remember, since it is a locomotor system, it produces a lot of disability due to the functional loss, whether it is the upper limb and the lower limb. The approach is by team effort. It involves the pathologist, the radiologist, and a number of clinicians like the orthopedic surgeon, the plastic surgeon, thoracic surgeons, the vascular surgeons. You would need the medical oncologist, the radiation oncologist. So the dictum nowadays is to have tumor boards, meaning when a patient of bone tumor presents in a clinic, you do a basic workup, which means clinical evaluation, the imaging, and then the patient is discussed on a common tumor board, which will have all these which are enumerated. So on day one, all the people in the team know what they're going to get, especially the pathologist knows the presentation. The radiologist knows that what needs to be investigated more if the investigations are incomplete, and a plan is made on day one. So as the treatment goes on, the biopsy reports come, the surgeries are done, the patient's response are noted. Again, the tumor boards will discuss the same patient together, and that is how the treatment is tailored and taken to a more meaningful outcome. So remember, approach to bone tumors is a teamwork, and tumor boards or tumor managing units are very, very important part of taking care. They present with a varied variety. The same tumor can have different clinical and imaging presentations. So thank you very much for your attention. I hope I have been able to share some basic things about bone tumors. I'm sure we'll come up with details on specific tumors in forthcoming lectures. Thank you very much.